Good evening to all. Today's my seminar topic is impact of HPV status on neck management in head neck cancers. Uh, First, we'll see the learning objectives of today's seminar topic. Uh, the first learning objective I have kept is the prognostic significance of HPV status in neck nodal disease. The second one is the impact of HPV status on therapeutic decision making for neck management. And the third one is the evolving concept of treatment de-escalation in HPV positive neck disease. First, we'll see the epidemiology of HPV associated head neck cancer. In oropharangeal squamous cell carcinoma, it has been seen as around 60 to 70% of the cases are HPV positive in most of are in developed countries. And in non-oropharyngeal squamous cell carcinoma, it has been seen as an incidence of 15 to 25% of the cases. And in cancer of unknown squamous cell carcinoma of unknown primary, it has been seen as around 50% of the cases as HPV positive. The HPV positive cases are more common in young age with male predominance and in non-smoker and non-alcoholic. It is mainly due to high risk HPV type, which is HPV 16 for 90% of cases. Less oftenly, it is seen as HPV 18, 31, and 33. Now comes to the mechanism of viral oncogenesis. The viral oncogenes E6 and E7 inactivates the tumor suppressor gene, namely P53 and RB respectively, which in turn promotes genomic instability that leads to development of cancer. HPV testing and its role in staging. Uh, According to the recent NCCN guideline, the HPV testing is recommended in all patients of oropharyngeal squamous cell carcinoma and cancers of unknown primary disease, where P16 IHC is kept as a surrogate marker of diagnosis of HPV positivity. The confirmatory HPV positive and HPV testing is done by IHC, ISH, that is in situ hybridization, and PCR is recommended in clinical trials only, which are based on HPV targeted therapy or de-escalation strategies. Due to small proportions and lack of prognostic significance, the routine HPV testing of non-oropharyngeal squamous cell carcinoma is not recommended by latest guidelines. Now comes to the what are the staging changes in oropharyngeal squamous cell carcinoma that are HPV associated. In HPV positive cases, the staging is mainly based on prognostic model, not on the prospective clinical data. First one, they have removed the T4 subcategory uh, in to defining the primary tumor, and in N staging, clinical N staging depends on nodal size and laterality, whereas pathological N staging is depend on number of node involved. They have also removed the pathological N3 category in the recent guidelines, AJCC 8th editions. The prognostic significance of nodal disease in HPV associated HPV positive oropharyngeal squamous cell carcinoma, they are usually having less small size of primary with multiple bulky and cystic nodes. This is due to high immune environment and a rich lymphatic uh, uh, source. It will leads to escape of early escapes to lymphatics and will results in multiple bulky and cystic nodes. But in spite of this, they have markedly better survival, which is around 58% reduction of risk of death as compared to HPV negative cases. The nodal disease can still adversely impact outcome in HPV positive cases when it is associated with macroscopic extranodal extension, matted nodes, or concurrent with smoking. In non-oropharyngeal squamous cell carcinoma, there is no survival advantage of HPV positive tumors. The survival now we'll see that why there is survival advantage in oropharyngeal pharyngeal squamous cell carcinoma, why not in oral cavity. So the first mechanism of this particular thing is that the viral oncoproteins, that is E6 and E7, better integrates to the oropharyngeal subsite, which will leads to the impaired DNA repair that will leads to increased radiosensitivity or chemosensitivity. The rich lymphatic tissue present in subsites of oropharynx, such as Waldeyer syringe and tonsil crypts, leads to strong immune surveillance, which will leads to increased tumor infiltrating lymphocytes. The viral antigen provides immunogenic targets that will enhance the tumor response. And last one is the definitive treatment in most of the oropharyngeal subsites are chemo, where the HPV benefit can be maximized. So this is these are the results due to better outcomes is seen in the oropharyngeal squamous cell carcinoma, which are all HPV positive. Whereas in oropharynx, there was no clear survival benefit. This is because HPV often act as a passenger infection in oropharynx, um, and P16 here is less reliable as compared to oropharynx. The microenvironment in oral cavity is less lymphoid rich with weaker immune response. There is a strong role of tobacco and alcohol, which will leads to high mutational burden and field cancerization. So, last one is the primary treatment of choice in oral cavity squamous cell carcinoma is surgery. These are the things which leads to no clear survival advantage in oral cavity squamous cell carcinoma in HPV positive cases, especially. This is the recent NCCN treatment of current NCCN treatment of choice in oropharyngeal squamous cell carcinoma. In early stage of oropharyngeal squamous cell carcinoma, the treatment of choice is resection of primary with ipsilateral or bilateral selective neck dissection that is based on laterality of or location of primary primary tumor, or we can give definitive RT or concurrent CRT, which is category 2B. The adjuvant therapy is based on adverse features, which are multiple nodes, LVI and PNI positive. Based on these, if adverse features are present, then we can go for adjuvant RT plus minus systemic therapy. If ENE positive node or positive margin is there, then we have to go for systemic therapy with radiotherapy. In locally advanced oropharyngeal squamous cell carcinoma that are HPV positive, the concurrent CRT is preferred. Although we can go for resection of primary with ipsilateral or bilateral neck dissection. Here, induction chemotherapy we can give, but it is category 3 recommendation from latest guideline, or we can go for clinical trial. Again, the adjuvant therapy is based on adverse risk factor. If these are present, then we have to go for adjuvant RT or systemic therapy based on risk factors. Now comes to the point that why there is de-escalation came. What is the rationale? What are the rationales for de-escalation? As we know that the standard treatment is the cisplatin-based chemoradiation therapy that will lead to significant delayed toxicity in terms of speech, swallowing, trismus, and dysphagia. The main aim of de-escalation to maintain cure rate while minimizing functional and quality of life impairment. So we have to go for careful patient selection. That is most important for safe de-escalation, such as we have to choose non-smokers, no adverse pathology such as extracapsular extension or positive margins. So one of the most important landmark trial, the post hoc analysis in a post hoc retrospective analysis of a landmark trial, that is RTOG 0129, in which they have tested 323 patients for HPV status. They have kept main determinants of risk factors such as HPV status, pack years, nodal stage, and tumor stage. Based on these risk factors, they have divided patients into three categories: low risk, intermediate risk, and high risk. Low risk are mostly HPV positive with favorable stage. Intermediate risk patients are mostly HPV positive with limited pack years of smoking, and high risk are usually mostly HPV negative or HPV positive with heavy smoking or high nodal disease. They have assessed 3-year overall survival, which was 93% in low risk. Intermediate risk, it has been seen as 70.8%, and high risk 46.2%. The HPV positivity rate in post-hoc analysis was 63.8%, and they have seen that there was markedly better outcomes in terms of 3-year overall survival and 3-year progression-free survival in HPV positive patient as compared to HPV negative. In HPV positive patient, they have seen the 3-year overall survival is 82.4% as comparative to 57.1% in HPV negative, whereas Progression-free survival is seen as 73.7% in HPV positive and 43.4% in HPV negative. The limitation was that it was post hoc analysis. It was mainly involved. It has mainly involved HPV 16 subtypes and based on chemoradiation cohort only. No surgical group has been taken. Uh, Based on these recommendations, there are some de-escalation trials in HPV positive oropharyngeal squamous cell carcinoma in adjuvant therapy, in definitive chemoradiation therapy, and in induction chemotherapy followed by definitive CRT. So, in comes to the point, the adjuvant in adjuvant therapy, the important landmark trial is the ECOG ACRIN 3311 trial that is conducted from December 2013 to July 2017. They have It is a phase 3 multi-center trial. They have taken resectable HPV positive oropharyngeal squamous cell carcinoma after transoral surgery, uh, whether to see whether we can give risk adapted low dose radiation therapy, or we have to go standard treatment. Again, they have divided patients into three groups based on this: low risk group, intermediate risk, and high risk. These risk group definition was taken as a pathology report of the tumor specimen. In intermediate risk group, they have randomized patients into low dose versus standard dose IMRT. The primary endpoint of this was to assess 2-year progression-free survival in intermediate group of the patients with low dose of radiation therapy. So it was similar between intermediate risk group of the patient who received low dose with standard dose. In low dose, it was 94.9% 2-year progression free survival, and in standard dose, it was 96.96%. So they have comes to the conclusion that de-escalation of 50 gray of RT is safe, effective for intermediate risk HPV positive oropharyngeal squamous cell carcinoma with excellent survival and with better functional and quality of life in low radiation dose group. Next trial in the similar mm, study is patho trial, that is phase 2 and continuation of phase 3 trial. It is ongoing phase 3 trial at present. They have assessed similarly after post resection of HPV positive oropharyngeal squamous cell carcinoma by transoral surgery, whether we can give a low dose of RT. And one important thing is that it is the only first trial which included both the de-escalation of RT and the omission of that chemotherapy in HPV positive cases. Again, they have seen the primary endpoint here was the functional outcome that is based on MD-ADI score, that is MD Anderson dysphagia inventing score, which was seen at 12 months of follow-up. In phase 2 trial, they have seen that it was in the functional outcome was better in intermediate and low risk group of the patients uh, with low dose of RT and omission of chemotherapy. And based on this, they have continued this in phase 3 trial, where the overall survival and quality of life was taken as endpoints. That are still recruited, and recruitment is completed, but the result is still awaited for phase 3 trial. In definitive CRT group, the de-escalation in HPV positive oropharyngeal squamous cell carcinoma, one of the important trial is NRG-HN002 trial. This trial has seen that in definitive CRT arm, whether by reducing RT dose, which is standard is 72 gray, by reducing it is to 60 gray with chemotherapy in HPV positive case, and whether we can achieve with tumor good balanced tumor control and improved quality of life. Uh, Similarly, here they have kept primary endpoints as progression-free survival, 2-year progression-free survival of 85%, and quality of life, swallowing quality of life by again MDADA score, which was kept more than 60. They have seen that 2 year survival, progression-free survival in IMRT plus cisplatin arm meet both pre-specified endpoint and justified the advancements to the phase 3 study. Limitation was that it is phase 2 study and with limited follow-ups, and they have selected good risk HPV positive population. The ongoing trials in definitive CRT groups are Evaders trial and LCC trial. In Evaders trial, they have it is the simple and not biomarker based, whereas LCC trial is based on biomarkers, but it is not validated till now. In LCC trial, they have taken a P53 mutation as a strategy to compare those patients which are P53 wild type. They have given de-escalation regimen with the reduced dose of CRT, but those who are positive for P53, they have not taken given them at reduced dose CRT. These are ongoing trials. Then comes to definite intensification of RT after induction chemotherapy. Here, one of important trial is E1308 trial. In this trial, in HPV positive oropharangeal squamous cell carcinoma, they have given 3 cycle of induction chemotherapy of cisplatin, paclitaxel, and cetuximab, and they have subdivided them into responders and non-responders. The responders are given reduced dose of RT, which is around 54 gray with cetuximab, and non-responders have been given standard dose of RT 69.3 gray with cetuximab. They have seen the progression-free survival and overall survival is almost equal between responders patient with reduced dose of RT. So they came to conclusion that induced response can guide us to safe de-intensification in HPV positive oropharyngeal squamous cell carcinoma. Similarly, Optima trial also conducted to assess the induction chemotherapy, uh, the role of induction chemotherapy in de-intensification of HPV positive oropharyngeal cancer. Here, they have divided patients into the low risk, intermediate, and high risk, and they have assessed the response by RECIST 1.1 criteria. And based on these, low and intermediate group have been seen as a excellent progression free and overall survival with preserved function and less toxicity. So again, they have came to conclusion that response and risk adapted de-escalation therapy is feasible, safe, and maintains outcome. Then come to one of the important trial that chemotherapy replace, whether we can give chemotherapy replacement in HPV positive oropharyngeal squamous cell carcinoma. We can't. The RTOZ 1016 trial shows that it is basically non-inferiority trial to compare RT with cisplatin and RT with cetuximab. They have seen that cetuximab has not shown non-inferiority, failed to show non-inferiority. Cisplatin still remains superior and is standard of care. And cetuximab is not safe to substitute for de-escalations. Uh, we have seen so much trial, but still, why de-escalation is not comes to in guidelines. Mostly, first thing is due to most of the conducted trials are phase 2 trials and single arm study. There was heterogeneous eligibility criteria such as different smoking cutoffs and staging system and subsites they have included. Again, the HPV status is misclassified. Some of trial include P16 alone. Some of trial include DNA with DNA and RNA confirmation. There was short follow-up also, so the late recurrences and toxicities was not fully captured. And important is the negative phase 3 data from RTOZ 1016 trial that cetuximab failed to show non-inferiority to with platinum replacement. Comes to the future prospects in de-escalation of HPV positive or oropharyngeal squamous cell carcinoma. There are a lot of trials conducting with immunotherapy integration with radiation, such as RT with anti-PD-L1 durvalumab, and they are also conducting neoadjuvant with followed by immunotherapy with RT to see whether we can, after giving immunotherapy, whether we can reduce RT dose without affecting survival and improving the quality of life is not, whether we can see or not. And again, we have to redefine the HPV definition. So we have to combine. We have to do combined testing of P16 at IHC along with HPV DNA and RNA testing to see more accurate risk classification. Um, then we have to move beyond P16 alone to avoid misclassification in non-oropharyngeal sites. There are novel biomarkers such as pi- uh, CA PIC case CA mutation. It assessed that the population which showed the positive for this mutation, poor association with HPV positivity rate. So the groups of the patient who shows positivity of PIC-CA mutation, we can't give de-escalation therapy them. And again, P53 alteration also linked to resistance to the that radio sensitivity and chemotherapy in HPV positivity rate. So by using, we further avoid de-escalation in them. Then again, circulating by using circulating tumor DNA, we can guide this can also guide us RT dose reduction on the basis of post-operative follow-up. By seeing the level of circulating DNA, we can choose whether we have to avoid de-escalation, or we have to give safe de-escalation. Thank you.
Thank you, Rakesh. Good presentation, and the most important thing is that you kept your time. The topic is open for discussion. Any questions to Rakesh?
I think the resident should participate here. Please ask questions. Afreen,
Yes, ma'am.
please ask him one question each from third years.
Yes, ma'am.
Rakesh, you have used three categories: low risk, intermediate risk, and high risk in multiple trials. So, were
Yes,
they
ma'am.
uniform? These
No, ma'am. These
categories?
were they were not uniform. That's why I have concluded in the limitations that they have not used the heterogeneous eligibility criteria in all
So,
trials.
what is the main criteria on which they divide these three categories?
Basically, some of trials divided these in patients into based on pathology report of the human specimen. Some of trials divided them in based on smoking risk factors also. So these were they were not homogeneous. That's why we can't take them into guidelines.
Rakesh, can you tell me the role of HPV testing in oral CA and how it affects its management and prognosis?
Although although there are limited data on the on there are no RCT as I've seen till now that on oral cavity squamous cell carcinoma the role of HPV status, but there are data to show the prognosis and the incidence in oral cavity. The incidence rate is usually less in oral cavity as compared to oropharynx, which I have shown in previous slide that oral cavity usually act as a passenger mutation, and in oropharynx there are some factors that will leads to more HPV positivity rate, such as uh, presence of tonsillar crypts, and the epithelium is not well keratinized as seen in oral uh, cavity. So there is a less chances of viral integration into the oral cavity subsides. So that's why the incidence is less, and the um outcome is also not seen as good as in oropharyngeal subsites.
Okay.
So Rakesh, does the effectiveness of immunotherapy depends on the HPV status? Is it more effective or less effective based on the HPV status?
Uh, there are running trials that are seeing effectiveness of immunotherapy in HPV positive oropharyngeal squamous cell carcinoma. They are seeing whether by giving along with RT or by giving induction immunotherapy, we can achieve the response rate, so we can de-escalate the RT in immunotherapy subgroups. But till now, I have not found any data regarding this.